Good morning, everyone. Though we have very few audience at present, I think slowly people will trickle in. And we have a very important topic, that is fungal diseases in transplant patients. I mean, it's not only transplant, there are many people who use immunosuppressive therapy, and the same thing can apply to other specialties also. So let's hear where we always do mistakes. The clinicians generally do mistakes in these kind of cases. Over to Department of Microbiology.
A very good morning to you all, and thank you, ma'am. So today we shall be presenting a CGR on transplant infections, rare fungal pathogens. So we know that infections are the leading cause of hospitalization in transplant recipients, and the risk of infection after transplantation changes over time, particularly with the modification of immunosuppressant. Solid organ transplantation has increased worldwide since the first successful human kidney transplantation, which was performed in 1954. As immunosuppressive agents and graft survival have improved, however, infection and malignancy have become the main barriers to disease-free survival after organ transplantation. Due to the growing population of immunosuppressed patients and with improved survival, and the use of improved diagnostic tools, it is seen that there's been increase in incidence and the spectrum of opportunistic infections in these group of patients. Therefore, prevention of infection is the key to excellent outcomes. Now, solid organ transplant recipients or hematopoietic stem cell transplant recipients are exposed to various types of complications, including rejection and mainly the graft versus host disease and infectious diseases, which include bacterial, viruses, and fungal infections, and occasionally protozoal infections. Now, invasive fungal infections are the major cause of morbidity and mortality in recipients of solid organ transplantation, as well as hematopoietic stem cell transplant recipients. The highest risks of infections are seen in small bowel transplantation, that is around 12%, followed by lung transplantation around 9%, liver transplantation around 5%, and heart transplantation around 4%, pancreas around 5%, and solid organ, that is renal transplantation, around 1.3%. Now, the factors that impact the risk of developing an invasive fungal infection includes the patient environmental exposure, as well as colonization with pathogenic fungi, and the use of antifungal prophylaxis, as well as the net state of the immunosuppression. In US, a 5-year prospective study was done by the Transplant-Associated Infection Surveillance Network. Although it's an old data, it is seen that they had studied around 1,063 organ transplant recipients, of which 1,208 patients were diagnosed with invasive fungal infections. Now, the most common fungal infections is usually invasive candidiasis, which is around 54%, followed by invasive aspergillosis, around 19%, cryptococcus in 8%, non-aspergillus mole infections 8%, endemic fungi infections in 5%, and mucormycosis in 2%. The use of more effective immunosuppressors, mostly fungal infections, occur within the first 6 months after transplantation. The overall cumulative incidence in the first year after transplantation is approximately 3%, although it varies depending on the type of organ that has been transplanted. However, the risk of infection, particularly to inhaled fungi, persists for many years even after the transplant. And it is seen that 2 to 14% of this invasive infectious complications are caused by opportunistic fungi after kidney transplantation. Therefore, the consequences of fungal infections can be very dire and include long hospitalization, increase in the cost, allograft damage, as well as high mortality rates. Therefore, today we shall be discussing interesting rare fungal infection in transplant recipients, and review of literature and the treatment options to guide the appropriate patient management. And we'll be presenting 4 cases, interesting cases, which are very uncommon. Some of them are common, but it is important that we diagnose. So early diagnosis is important. And in these patients, the preventive aspects is also very important. I call upon my senior resident, Dr. Ashima Singh, to present the first case. Thank you.
Thank you, ma'am. And good morning, everyone. I'll be presenting an overview on transplant-associated infection, followed by the first case presentation. Coming to the basics of transplant infections, as we all are aware, these infections, they occur on a time scale. The type of transplant and the frequency of infection varies depending upon the type of transplant. More the immunosuppression, it will contribute to more infection. The varied presentations further make the diagnosis difficult, especially in cases of fungal infections. So there's a continuous interplay between these three factors, that is rejection, immunosuppression, and infection. So once there's rejection, to combat this rejection, we create a state of immunosuppression, which makes the individual vulnerable to different types of infection. And with the introduction of many new immunosuppressive agents, the timeline of etiological agents varies. So it is very important to understand the timeline of infection following a solid organ transplant. So within less than 1 month, we see the predominance of bacterial pathogen and more of surgical site-related infections. And also there's a dominance of donor-derived and recipient-derived infections, especially the cases like aspergillosis are reported. Within 1 to 6 months after a transplant, there's a rise in the latent viruses like herpes simplex viruses, CMV, EBV, and varicella zoster virus. After 6 months, as the body has adapted to the immunosuppression, there's a rise of community-acquired pathogens and also the infection with aspergillus, atypical molds, and mucor species predominates. So less than 1 month is often donor and recipient derived. 1 to 6 months is the reactivation of the latent viruses, and more than 6 months is generally community acquired. So what you need to know about fungal pathogens. Fungal infections can range from mild to life-threatening fatal illnesses. These infections can mimic bacterial or viral infections, so it is very important to understand the exact etiology and pathogenesis. The geographical conditions play a very important role. We should know the endemicity of a fungus, and also the travel history is very important. The duration of hospital stay is of prime importance as we see the rise in Candida auris cases in the ICU settings. Some types of fungal infections are more common in solid organ transplants like aspergillosis, candidiasis, cryptococcus is more seen in lung transplant followed by the other transplant. And as we see the timing of invasive fungal infection after a solid organ transplant, it varies depending upon the type of transplant, that is the solid organ and hematopoietic stem cell transplant. In a solid organ transplant, initially we see the rise of candidiasis, followed by aspergillosis, zygomycosis, and pneumocystosis in the later part, that is after 6 to 12 months. In hematopoietic stem cell transplant, the patient can either present with an early onset of illnesses with candidiasis, aspergillosis, fusarium illness, and zygomycosis, or the patient can either present very late. So these depend upon various factors, that is the host factors, the virulence and latency of the organism, and also the different degrees of immunosuppression the patient is undergoing. So coming to my first case presentation, a 70-year-old male, resident of Mirzapur, Uttar Pradesh, he presented to the nephrology OPD on 21st September 22 with chief complaints of high-grade continuous fever for 14 days, dry cough for 7 days, and shortness of breath for 2 days. The patient gave a history of live-related ABO-compatible renal transplantation, which was done in 2009 at a private hospital. He was on triple immunosuppression. Acute graft dysfunction was reported in 2019, for which he was hospitalized here. The patient was a known case of diabetes mellitus and hypertension since 6 to 7 years and was on medication for the same. So as we can see here, the transplantation was done in 2009, and now the patient is presenting with this illness in 2022. That is, it has been more than 10 years. Investigations on admission, the routine investigations were within normal limits. The chest X-ray at admission showed bilateral lower lobe paths, which was suggestive of pneumonia. On further interrogation, the HRCT of chest showed multifocal patches of consolidation with centrilobular nodule and few of them showing internal areas of cavitation. Pleural fluid was sent for investigations of fungal and bacterial culture and sensitivities, which yielded negative results. Gene expert was negative for Mycobacterium complex. So thinking it to be some invasive infection, a lung biopsy was planned. The lung biopsy sample was sent to the mycology lab on 4th October 22. So on day 1, the microscopy was done on a lung biopsy crush smear, and we could easily appreciate this capsulated budding yeast against a dark background. And this was suggestive of a Cryptococcus infection, and we reported it on the day 1. On day 7, here we can see the mycoid colonies observed on the Sebarod's dextrose agar slant, shown in the blue arrow, and small tiny gray-brown colonies observed on the caffeic acid agar, shown in red. So this is a special media used for Cryptococcus species. On day 7, when the culture grew the colonies, the gram stain was performed and it showed gram-positive spherical budding yeast cells with a narrow neck budding. So supporting our diagnosis, on day 8, urease hydrolysis test was done and it was also positive for the species. And the positive is shown in pink color and the negative is pale. Further identification was confirmed using MALDI-TOF mass spectrometry, and the isolate was identified as Cryptococcus neoformans. Additional tests that were put up were Calla's cryptococcal antigen detection test, which was positive, and CGB agar. It is a special media that is canavanine glycine bromothymol blue agar, which differentiates between the Cryptococcus neoformans, Grubai, and Gattai species and neoformans. So in Cryptococcus gattai, we get a cobalt blue color, which is shown in the dark blue color. So it is a diffuse blue color in the media. And in neoformans, there's no change. So final diagnosis of pulmonary cryptococcosis in a post-renal transplant recipient was made. The patient was started on amphotericin B, oral flucytosine 500 mg twice daily, adjusting the GFR. He was also given voriconazole 200 milligram OD for 7 days. The patient became afebrile and cough and breathlessness resolved gradually. Resolution of lower lobe patch after 1 month was observed. So as I conclude my case, there's a brief review on the characteristics of this species. So the Cryptococcus, they are Basidiomycetes fungus. They are oval to round capsulated yeast that reproduce by narrow neck budding. The most common environmental source of Cryptococcus neoformans is pigeon droppings. And the most common mode of transmission is also by inhalation. Infections seen are of varied presentations like CNS, pulmonary, skin, bone, and disseminated. An important characteristic to note is the intrinsic resistance to echinocandins. It grows on Sabarod's dextrose agar as white to cream colored mycoid colonies within 48 to 72 hours. So the classification of the fungi, it is Cryptococcus neoformans, is placed in serotype A and D, which is commonly seen in immunocompromised individuals. And Cryptococcus gattai is often reported from immunocompetent, and it is placed in serotype B and C, followed by the hybrids, which can be reported in different case scenarios. So it is the third most commonly occurring invasive fungal disease in solid organ transplant recipients, and it is a late occurring invasive fungal infection. It may occur after 1 year or even after 10 years. So induction agents like alemtuzumab, anti-thymocyte globulin, steroid use, diabetes mellitus, lower socioeconomic status, and older age are the risk factors. Mortality rates can range from 10 to 25% and can be as high as 50% in solid organ transplant recipients with cryptococcal meningitis. The literature reported from our center, 22 patients out of 2362 renal transplants were positive for cryptococcal meningeal infection. Cryptococcal infection has an incidence of 0.04 and associated with significantly higher mortality rate of 18%. The therapy for patients with CNS and the disseminated diseases, The first phase is the induction phase, which is a phase of 2 weeks given with liposomal amphotericin B plus 5-flucytosine 100 mg per kg in divided doses. Doses of flucytosine and fluconazole should be adjusted according to the glomerular filtration rate, and monitoring of flucytosine level is recommended. In the consolidation phase for next 8 weeks, we give fluconazole 400 to 800, followed by the phase of next 12 months, that is fluconazole 200 and 400 mg per day. In case, and it is very important to note that after the induction phase, we should repeat the sample for testing in the mycology lab. In cases of relapse after induction therapy and in vitro testing, there's a salvage therapy which is recommended by the IDSA guidelines, where fluconazole, voriconazole, and posaconazole are given for 10 to 12 weeks. So here I conclude my first case. I would like to call Dr. Sabha on stage to continue with the presentation.
Thank you, Dr. Ashima. I'll continue with the second case. A 42-year-old male post-renal transplant recipient in 2014 presented on January 2024 to the nephrology outpatient department with chief complaints of slowly progressive swelling over lateral aspect of left elbow over the past 1 year. There was mild pain with constant discomfort in the swelling. He denied any proximal or distal radiation of pain. History of past illness. He was a known case of CKD, biopsy proven on diffuse global glomerular sclerosis, immunoglobulin A nephropathy since May 2012. He gave a history of blood transfusion in June 2012 for anemia, after which he contracted hepatitis B and C, which was diagnosed in January 2013, for which he was put on entecavir with negative viral load till date. He underwent live-related ABO-compatible kidney transplant in April 2014 and was put on triple immunosuppression of tacrolimus, mycophenolate mofetil, and prednisolone since the transplant. He had creeping rise of creatinine since July 2021. Further graft biopsy was done, which was suggestive of active antibody-mediated rejection. So it was a gap of 10 years, after which he presented with the skin lesion, and local examination of the swelling was solitary, well circumscribed swelling of 3 to 3 centimeters in diameter was seen. Surface of the swelling was smooth, tender on palpation, minimally mobile, soft to firm in consistency. There was no axillary or supraclavicular lymphadenopathy. Patient had full range of movements at the elbow joint. History of present illness. Patient had an asymptomatic nodule of size 0.5 centimeters on his left arm since 25 years. He did not provide any history of trauma to left elbow. His general and systemic examination was within normal limits. His routine laboratory investigations of CBC, electrolytes, and serum proteins was within normal limits with deranged KFT. His creatinine was 3.93 milligram per deciliter. His LFT parameters were within normal limits. He underwent ultrasound and MRI of the left elbow swelling, both of which showed multi-loculated thick wall cystic collections with no bony infiltration. Fine needle aspiration cytology of the aspirated pus was sent, and on periodic acid skip stain, plenty of neutrophils with septate fungal hyphae were seen. No granuloma, atypical, or malignant cells were identified. FNAC guided pus aspirate was sent to microbiological lab, and on KOH mount, tissue debris and plenty of pus cells were seen. Plenty of pigmented septate acute angle branched fungal hyphae were seen. As the QH mount showed pigmented hyphae, so it was suggestive of pheohyphomycetes was reported, and culture reports were to be followed. The sample was put on, cultures were put for the samples and were incubated at 25 degrees centigrade and 35 degrees on Severod's dextrose agar, which showed growth of pigmented colonies within 2 weeks of incubation. Figure A and Fig B shows the obverse and reverse of the colonies. They were slow growing, initially yeast-like velvety black colonies, and later changed to mycelial-like growth. Fig B shows the olivaceous black color colonies. Lactophenol cotton blue mount from the tube cultures were made, which did not show conidiogenesis or any fruiting bodies. Later, microculture of the colonies were put on malt agar. Takedown from the malt agar was done, and lactophenol cotton blue mount was made, which showed septate hyphae with numerous conidiogenous cells that are slender, tubular, tapered to a narrow, elongated tip shown by the black arrow. Also, conidia developed from swollen moniliform bead-like annelophores. Fig B shows whorls of septate pigmented hyphae. LPCB mount was morphologically suggestive of Exophylla monillae species. Final diagnosis was made a subcutaneous pheohypomycosis due to Exophylla monillae in a renal transplant recipient. He was started on oral voriconazole 200 mg BD. Surgical excision was planned, however, due to patients' financial constraints could not be performed. Final confirmation of the isolate will be done by sequencing. A brief note on Exophylla species. As we know, fungal pathogens are seen in two morphological forms, yeast and mold forms. Molds are of two types, septate hyphae and aseptate hyphae. Septate hyphae can be seen as hyaline, colorless fungus or pigmented fungus. Pigmented fungi are also called as dimetaceous fungi. Dimetaceous fungi can present with various infectious diseases like Madura foot, chromoblastomycosis, and pheohypomycosis. Taxonomy of Exophylla species, it belongs to phylum Escomycota and order Chaetothyreales. And these are the various species of Exophylla. Ginselmia is the most common species found, followed by Dermatitis and the rare species Spinifera, Monalia, Xenobiotica, and Asiatica. Habitat of Exophylla species are found in abundance in extreme natural habitats on decaying organic matter like wood, found in hot, moist, artificial environments such as steam baths, sauna, and bathrooms, in dishwashers, and they can also be colonizers in the respiratory tract of cystic fibrosis patients. Epidemiology of pheohypomycosis. Incidence in India amongst post-renal transplant recipients is about 8.3%. Most commonly, the infection is found in renal transplant patients, about 67%, followed by heart transplantation, 11%. In solid organ transplant recipients, most common infection is of skin and subcutaneous tissue, which is 60 to 70%. Exophylla dermatitis is the third most common species causing disseminated pheohypomycosis. Exophylla dermatitis is isolated from respiratory samples of cystic fibrosis patients is at a rate of 1 to 19%. Most common risk factors reported are trauma, 33.3%, followed by post-renal transplant immunosuppression at 12.1%. Infections caused by the Exophylla species are skin and subcutaneous infection, keratitis, bacteremia, central line associated bloodstream infections, infective endocarditis, pneumonia, brain abscesses, sinusitis, chromoblastomycosis, and Madura foot. I conclude my second case. Now coming on to the third case. A patient of 40-year-old male, a live related renal transplant recipient in 2017, came with complaints of multiple painless nodules on his back interscapular area for 2 months, September-October 2018. The history of present illness, patient noticed a small nodule in his interscapular area 2 months ago. There was a single nodule initially, not associated with pain or itching. Gradually, it increased both in number and size, and multiple discharging sinuses appeared over the lesion. The patient gave a history of injury to his back 2 to 3 months ago. History of past illness was known case of CKD, hypertension since 2015. The patient underwent live related ABO-compatible kidney transplant in June 2017 and was put on triple immunosuppression therapy of tacrolimus, mycophenolate mofetil, prednisolone since the transplant. Now he's coming after 1 year of transplant in 2017, and now it's at the presentation, it was 2018. Local examination of the lesion, multiple violaceous nodules with discharging purulent sinuses present on the interscapular area were seen. Some lesions were firm and some were fluctuant, containing pockets of pus. Clinicians had the suspicion of nocardia infection. Further, MRI of the spine was done and cutaneous and subcutaneous involvement without deep tissue and bony infiltration was seen. The pus was aspirated and sent to microbiological investigations, on which in KH mount we found pigmented septate branching fungal hyphae with hyphal swellings. And on gram stain also we found pigmented septate branching fungal hyphae. KH mount and gram stain suggested as it was pigmented hyphae were seen, so it was suggested of pure hyphomycetes infection, and it was reported fungal cultures were to be followed. The sample was put on SDA agar at 25 degrees centigrade and 37 degrees, which showed growth of pigmented colonies within 10 days of incubation. This is the obverse and reverse of the colonies. The obverse is white to gray colonies can be seen, and the reverse black pigmentation can be seen. LPCB mount from the tube cultures were made. Characteristic two-celled dark brown longitudinal striated mature conidia were seen. Fig A shows the immature conidia without striations, and Fig B shows dark brown mature conidia with longitudinal striations. The isolate was identified by automation using MALDI-TOF and sequencing and was identified as Lesidiodiplodia theobrome. A final diagnosis of subcutaneous pure hypomycosis caused by Lesidiodiplodia theobrome was made. The patient received tablet itraconazole 200 mg BD for 2 months. The lesion subsided, seen in Fig A, and he underwent a wide excision of the lesions along with skin engraftment after 2 months of itraconazole therapy. There was no recurrence after 2 months of therapy. I conclude my case and I invite Dr. Jolly to present the next case. Thank you.
Thank you, Dr. Sabha. I'll be presenting with the 4th case scenario for the day. A 32 years male presented on 4th July 2023 to the nephrology outpatient department with a chief complaints of fever for 15 days, abdominal pain for 5 days. He was a post-renal transplant patient where the transplantation was done on 30th of August 2022 with the induction therapy of anti-thymocyte globulin. USG abdomen showed enlarged liver with well-circumscribed hypoechoic lesion in the right lobe, and CT abdomen showed a liver space-occupying lesion of 10 into 8.1 centimeter. These were the lab investigations. It was seen that the serum creatinine levels were increasing on the day of admission. Also, it was high, and after 4 to 5 days, also it was high, and the SDOT and SGPT levels were also deranged. The aspirated fluid was sent to the microbiology lab, and 10% KOH mount was prepared. So, as can be seen from the first and second images, the 10% KOH mount showed plenty of tissue debris, pus cells, and RBCs, and there were plenty of hyaline broad aseptate ribbon-like hyphae showing right angle branching. So from these, we made a suggestive diagnosis of mucormycetes, suggestive of hepatic mucormycosis. Culture was done in Sabrod dextrose agar and incubated at 25 degrees Celsius and 37 degrees Celsius. After 1 week of incubation, fluffy cottony growth was observed. So an initial suspicion of Epiphyomyces species was made, but no yellow pigmentation was seen on the reverse. Therefore, a suspicion of Saxinia species was made. For further confirmation, the inoculation was done on water agar. The first image shows the water agar. So a LPCB mount was made from the water agar culture, as shown in the second image. Broad aseptate hyphae was seen with right angle branching, but no sporulation was seen. Repeated subcultures were done on water agar for the sporulation. In the meantime, calcoflower white staining was also done, and we observed aseptate right angle branching fungal hyphae. Despite repeated subcultures for 2 months, sporulation was still not observed. A typical LPCB of Saxinia species, which we were suspecting, would give an image as shown. We should get flask-shaped sporangia with columella and dark pigmented rhizoids. But since sporulation was not seen even after 2 months, The isolate was sent to Chandigarh for sequencing. The region was ITS28S rDNA, and the isolate was identified to be Saxinia vasiformis after sequencing. So a final diagnosis of a case of hepatic mucormycosis with dermal involvement in a renal transplant patient was made. The image was the patient presented with a blackening and a Eschar formation above the skin, above the liver area in the later days of admission. This might be because of the angio-invasive nature of the mucorale species, which might lead to disseminated infection, explaining the dermal involvement and the necrosis. He was started on dual antifungals, including liposomal amphotericin B and posaconazole. Surgical debridement and lobectomy was planned. However, his family did not consent for the surgery. He developed cardiac arrest on 12th July 2023 and succumbed to his illness. A short review on mucormycosis in transplant patients. Mucormycosis is an emerging life-threatening invasive fungal infection in immunocompromised patients in the past decades. It is associated with the longest duration of hospitalization and the shortest 2-year survival in renal transplant patients, although it comprises only 2 to 6% of the invasive fungal infection. Saxinia vasiformis belongs to the order Mucorales. The infections caused by Saxinia comprises only 3% of the infections caused by Mucorales, and it mostly occurs in the immunocompromised patients. The known risk factors according to the Western literature are hematological malignancies, hematopoietic stem cell transplant recipients, and patients with neutropenia. And according to the Indian literature, the risk factors for mucorale species are neutropenia, high-dose corticosteroids, diabetes, hematological malignancies, solid organ transplant recipients, and malnourished patients. The diagnostic algorithm for a suspected and confirmed mucormycosis is they are emergencies and they require rapid action. In a hematopoietic stem cell transplant patient or a solid organ transplant patient who is neutropenic and presents with persistent fever or respiratory symptoms, a chest CT should be done. And in Asia, specifically in India and China, patients might present with no underlying illnesses with vague symptoms like flank pain, fever, and hematuria. In India, we get mostly cases of isolated renal mucormycosis. An ultrasound or an abdominal CT should be done. Once the radiological investigations are done, the samples should be sent to microbiology lab for confirmation. Most preferred sample is biopsy, endoscopic or CT guided. The samples are subjected to direct microscopy in the lab, where the typical findings would be non-septate or pauciseptate ribbon-like hyphae, and culture will be done where the typical finding is cottony white or grayish black colonies, and molecular identification will be done, preferably semi-nested quantitative PCR, high-resolution melting analysis, or multiplex analysis. For the management algorithm in solid organ transplant patients in suspected and confirmed mucormycosis, again, they are emergencies and require rapid action. Surgical debridement with clear margins should be done for disease control, for histopathological investigation, and microbiological diagnosis. Plus, immediate treatment initiation should be made. The mode of treatment is liposomal amphotericin B, 10 mg per kg per day from day 1, and weekly response assessment should be done. In this, if the patient has a stable disease or shows a partial response, then we can continue the first-line treatment or change to oral treatment, that is isavuconazole. Or if there is a progressive disease, then intravenous isavuconazole will be given. And if a toxicity develops to the prior treatment, then intravenous isavuconazole or intravenous posaconazole can be given. This chart shows the prevalence of invasive fungal infections in solid organ transplant recipients. So as can be seen from the image, in most of the solid organ transplant patients, invasive candidiasis, shown by the blue color, is the major contributor for the invasive fungal infection. But as seen in renal transplant, from the data in India, we can see there is a mixed prevalence of almost all the infections, that is invasive candidiasis, cryptococcosis, invasive aspergillosis, endemic mycosis, mucormycosis, pneumocystosis, and pheohypermycosis. Till the 1950s, there were only few antifungals that were available. Newer antifungals were added to the list, but in due course of time, resistance was also developed against most of these agents. So there is a necessity for newer antifungals. So these are the 4 newer antifungal agents in the pipeline: Fosmanogepix, Ibexafungab, Olorofim, and Rezafungin. Fosmanogepix has a spectrum of activity against yeast and molds, especially those including those with resistance to echinocandins and azoles. Ibexafungab has an action against Candida, Aspergillus, and Pneumocystis. Olorofin acts against mold and dimorphic fungi. Rezafungin acts against Candida and some Aspergillus species. Rezafungin has promising action against Candida, especially the multi-drug resistant Candida auris species. Ibexafungab has been approved by FDA for the treatment of vulvovaginal candidiasis in 2021, and Rezafungin has been approved by FDA for treatment of candidemia and invasive candidiasis in 2023. Now I request Dr. Rumi S.K. Marak ma'am to give the concluding remarks.
So what are the points to keep in mind when dealing with fungal infection in transplant recipients? The most important thing is awareness regarding the timeline of infections in this group of patients and the prevalent fungal pathogens. And you should be aware and have high index of suspicion. The knowledge of emerging opportunistic as well as rare fungal pathogens should be there. Appropriate and optimal sample collection is very important. It is important to discuss with the microbiologist, and then for a suitable sample to be collected, optimal collection, the quantity is also important. And for mucoral infections, it is important to send a biopsy and not or a pus aspirate and not a nasal swab or swab samples. Although we accept the swab samples because sometimes we may find, it is not that we are rejecting them, but it is very important to send the biopsies. The biopsies should be sent in sterile normal saline and not in formalin, because we do receive in 10% formalin, which is important because we may not be able to culture and speciate the organism. And we know the speciation is very important because they have different susceptibilities. Some of them are intrinsically resistant, so we have to know the species. The biopsy samples should be sent simultaneously to microbiology and histopathology because histopathology will show the invasion as well as the tissue reaction. And it is important to identify the pathogen, and it is really time consuming. However, there are newer techniques of diagnosis, and it is important to do a fungal microscopy, 10% QH mount, which usually in half an hour we can give a report. But we usually give them in the morning sample, which it come morning sample in the forenoon, in the afternoon. However, biopsy samples as well as thick pus skin nails should be kept for digestion. So we may give it the report only after 24 to 48 hours. Special stainings can be done, like calcoflow white staining, the Gomoris metanamyl silver, which stains the fungal brown-black, and the Giemsa staining. And for few hyphomycoses, a PS staining is very good. It is it's a what you call vital stain, and you can see the organisms. And quantinimation staining is usually done for pigmented fungi. So we should wait for the culture results, and then we do the lactophenol cotton blue, and we're able to identify these organisms in phenotypically. However, there are few pathogens it is difficult to identify, so we have to do the sequencing or do a PCR. We have the latest armamentarium for diagnosis, like this the matrix-associated assisted laser desorption time of flight assay, which is a mass spectrometry, which we have in our department. However, this machine will detect only pure cultures. So it will identify the organism within 5 minutes. The species ID will be there depending on the library or the database that is present in the equipment. And however, as I told you, that some may require sequencing for the identification. Thank you very much. So I would say that you have to think of fungus. You have to be aware of fungus. So the most important thing is rapid diagnosis or early diagnosis and aggressive management for treatment of these patients. Thank you very much.
So thank you, Dr. Rumi. You can join us here. So questions from the audience first. Yes, Dr. Moinek.
Thank you very much. Yes. So, like organisms, like for bacteria, it will take at least 18 to 24 hours or even take 40 years for the cultures to come. So once the culture comes in pure form, only then we can do the Malitov. We cannot do it direct from clinical samples. Yes. No, we have to do the culture first. So this machine will identify only pure isolates. We do have mixed infections like during COVID, we had aspergillus as well as mucormycetes. So we have to separate them. So if you do mixed cultures, if you do Malditov, then it will give a wrong ID or it may not identify. Yes.
Infections in the have come from one to Canada.
Yeah, surprisingly for transplant recipients, although the candida, invasive candida or candidemia is more common, but somehow we have not found that there's an increase in candida species. However, hospital-acquired infections, that is HAIs, we are getting a lot of patients, especially those who are on uh, what you call central lines. Those patients, it is usually seen that we have quite a increased rate of candidemia as well as invasive candidiasis. So if you see, we have the most in Southeast Asia, we have more of tropicalis. Candida albicans used to be the first common species, but in our hospital, we have Candida tropicalis, which is much more commoner. And we have Parasalopsis, which is actually, it is known to cause biofilms in the central lines. So we have Parasalopsis and we have Candida auris, which is a hospital-acquired multi-drug resistant organisms. It is in our hospital, all of them are resistant to fluconazole, and some of them do have higher MICs to amphotericin B, and some of them are even resistant to echinocandins. So although the drug of choice is echinocandins, I know it is very expensive. And we are planning to have the BDG. So we have the equipment has been sanctioned by Director Sir, so we will be able to give a biomarker for invasive fungal infections. The negative predictive value for this is very good. So in febrile neutropenias, then if you have BDG negative, then we need not give them such expensive antifungals.
Just had two questions. One was that you showed in the last case that the skin necrosis or something had occurred at that site. Was it the same site where the aspiration was done? Because you can get colonization. No, okay, fine. Maybe the clinician can answer that question. And why did you do a skin graft in that patient? I mean, with the skin lesion at, okay, first case.
So actually, it was the extension of the fungus to the skin.
Okay.
It was the whole track.
Okay.
Actually, madam, he had only in the liver and he was asked for doing a resection, but he refused. By the time, since it is highly angioinvasive, it is highly necrotic and it is known to cause infarction. It spreads to the blood vessels, both the arterial as well as venous, and they caused dermal infection. Involvement was also there.
Yes, Dr. Sina. After that, Dr. Manoj.
Yeah, it's a proteomic. So it is actually depending on it's a proteomic, it's not nucleic acid, proteomic system where uh, the lighter proteins, they fly earlier. So, and the larger proteins will move slowly. So in a vacuum channel, the thing is done and it takes hardly 5 minutes. Yeah. You can come and see the machine. Yes. Yeah. We have a library. We have a library there at the database. So depending on that, it is an in vitro diagnostic method. We don't have the research only. Yeah. Yes, sir. Yes. Yes, sir. It is never done in mixed infection. You have to have pure culture. You have to have isolated colonies, and then it is done, because it will give you mixed infection. Sometimes it has its own fallacies, like Shigella and E. coli. It will not differentiate. There are some organism it doesn't differentiate. It will give you a percentage, and we can see the graphs. Yes. Mixed infections, no, sir. No. There are two systems. We have the Bruker. They have the research also use. So we can add on the libraries. But however, every species prototype, at least 15 to 10 species, you have to sequence it, then you put it in the library. So that is possible with Bruker. But this Biomary, which we have, they have their own library and they keep adding on, and then it gets updated. Yeah.
But if you have mixed infection, you can pick up the two colonies separately and then analyze. So then you can get good results in that. Dr. Manoj.
Actually, sir, it is not. It is virulent. You can see the resistance, like Candida cunningamella species is usually more resistant. So the treatment, there would be difficulty in treatment. And as such, virulence for different species is not. But like for cunningamella, normally they will not be responding to ampho also. So we have to know the species. For epidemiological purposes, I think it is important to know the species, what is the prevalent species in your locality. However, for Candida, it is very important. And for Aspergillus, because Candida, like we have intrinsically resistant Candida, like Krusei, it is intrinsically resistant to azoles. And then we have Glabrata, which can, as you start treating, they will increase in MIC to fluconazole. And Lusitania, it is resistant to, again, amphotericin B. Like for species of Aspergilli, we know the Teria species is intrinsically resistant to ampho. And species like Schistosporium, again, intrinsically resistant to ampho. So there are pan-resistant organisms like Lentulus, which is again emerging. So it is important to know species because the treatment varies. Mucormycosis virulence as such is not. They can only thing, the problem with this mucor is it is a medical emergency and it has to be diagnosed early. It has to be treated aggressively. Like you have to manage the metabolic, like if they're having, yes, all that you have to do. Then you have to do surgical debridement with wide excision. And it is important that therapy is started early. Liposomal amphotericin has really helped in, like you can give high dose and it is nephrosafe also. It is important. Which one, sir? Yes. So what happens is that in mixed fungal infections, when we do a microscopy, we do see different types of hyphae. You may have hyaline hyphae with pigmented. You may have broad aseptate with hyaline. So when we think of it, we'll think hyaline hyphae is with a septate. We could think the most common species Aspergillus, but it could be there are so many species which are hyaline and septate acute angle branched, like Fusarium, Schistosporium, we have Bacillomyces, we have different species. So it is important that we do the culture. When we do the culture, we look at the cultures every day, and then we see that there are different types of colonies which are growing. We have to separate them. So every day we do the reporting and we separate them, and we have to isolate only then. But sometimes it is difficult, like Aspergillus grows very fast. So it is important that when we're having a mixed infection, it is important to separate. And histopathology will definitely give you the different, you can see, you may have few hyphomycosis along with Aspergilli. You may have Aspergillus with mucor or with Candida. So one thing about that Exophiala species, it is very important to identify because I think the patient is planned to come back for surgery. I was told by the resident. It is known to be, it can disseminate and it can cause bloodstream infections. And if you see that dishwashers mein hoti hai, sauna bath mein, so it is important they can colonize. So these patients who are immunocompromised, they can get infections from the environment. Yeah. Nee, Mohan. Yes. Acha. It was not given positive. It was not. Actually, you will find the fungus in the dirty part only. In the necrotic part only, you will find the infarcted tissue. You will find. But didn't we give a positive report for this? Acha. Okay. Okay. It was. Did he respond to AMPHO? Acha, succumb before treatment. Okay.
Some of the patients are very sick, you know, from the past, last year, is there any thought of using from molecular? Because like in microbacteria now, we are looking at for our is there any role of from molecular after that? And there is no look all those patients that balance between honor, doing application and honor execution. So do use the immune substitution where the patient can't be living from the institution, then we use the actual. So this is definitely the state of environment, the bad state of school, and the bad state of the you can see that the two patient suppression was not except in the last patient who is speaking. Sometimes they have this very high exposure. Most of their patient they are residing in the places and they have higher exposure than comparison to other population. Yes, sir, over the after the 6 month emergency we started reducing immunosuppression, especially micronutrients. So if somebody is on a 4 tablets, we will be doing or like we will 4 tablets for maximum and make it fully and give the patient on that problem. Especially when they develop that point of time, you can do the practice of prevention and at the time of prevention, micronutrients we continue with CMI and those.
So to your question regarding rapid diagnosis, definitely there are commercial platforms available for RT-PCR and PCR. We also tried using, but we didn't get good results. But I think we still have to work on it. And if you look at the MSG, the consortium, they have standardized for Aspergillus PCR, but not for others. But for pneumocystis also, there's a very good PCR. And we are planning to get the syndromic diagnosis for multiplexing for multiple pathogens. In that, we have few of the fungal pathogens. So I think in near future, we'll be able to give a rapid diagnosis. And we have the biomarkers like the BDG, which we are planning to get it. So that will also help. It will detect all types of fungal infections. The negative predictive value is very good. If it is negative, then we can think it is not because of fungus, as we know that fungus can mimic bacterial or viral infections. And we have the galactomannan. The galactomannan is, they say it is specific for Aspergillus, but it is not. But this will also give you the values. More than 0.5% serum galactomannan will talk about invasive septic fungal hyphae infections like Aspergillus.
I think rare might be in terms of other subspecies. So I like we was very often in the whole transplant setting, and interestingly, patient of patient pure hypohypothesis actually actually means very rapidly they diagnose whenever they see any various they pick it up, they screen and they immediately identify the evening and we start getting and nowadays like after 5 to 6 years once we have like talked to them maybe the source control is required in the patient. Now we are not seeing this pure hypothesis. Now we are instructing all patients to wear the actually they should not walk
Barefoot.
barefoot.
Yeah.
Maybe they have a bunch of trauma. I think they're looking, but I think that what there is I think some species or what we have something. But my question is, but we didn't talk about
Yeah, they're common. That's what, after talking to the nephrology, like even Dr. Dharmender, these patients, when they come with one nodule, then they do a whole body examination, whether they're having nodules elsewhere. So this is how we are able to prevent and, yeah.
Yes.
There's geographic location and type of infections. Mhm. That is difficult to tell, but if you see, we see a lot of your hypomycosis, and we have got very rare species like Acrophyalophora fusophora, which we diagnose phenotypically, and we would send it to the referral lab in PJ Chandigarh. They confirmed it Acrophyalophora fusophora. So, and we have lot of almost all species of mucorales. This is the first time it has come to our laboratory, Succinia. Others, we are getting Rhizopus homothalicus, we get Apophysomyces, we get Cunningham, we get Syncephalostrum, and very rare, we get mucorales. And for few hypomycosis also, we have almost different species. We have seen Exophiala dermatitis, we have seen Spinifera, and we have also seen Genselmi, and this is the first time we are getting this new species. First time it has come. Yeah. That regarding that uh, skin grafting. So this patient, initially we were told that they're suspecting nocardia or some bacterial. And surprisingly, this